So without further ado, I'd like to introduce our guest speaker for the day. I've given him a tough assignment. I've asked Dr. Gerald Friedman, who is a well-known and well-regarded economist. He's professor of economics at the University of Massachusetts at Amherst. I'd like to plug his book for a moment, The Case for Medicare for All. I encourage all of you to read it. It's an easy read. It's well-written. It's from the heart, and it's available on any of the local book websites. I'm not going to single any of them out. But Dr. Friedman, welcome. I hope you will help us with the nuts and bolts of how we can get our New Jersey state legislation a little bit more publicity and show everyone that it can work.
Well, thank you very much for that kind introduction. And, try to buy my book at a local independent bookseller. But you can get it on Amazon. I've been doing this sort of work for a while, and I appreciate all the help that I've had from Tom and from Lloyd. So it's been interesting. I think you guys have an interesting alternative to the improved Medicare for all. I've been at this for a long time. The first active work I did was I say here 1979, but that's wrong. It was 1978, long ago. But I was working at the International Ladies Garment Workers Union. For 1 year, I was an honest person working 9 to 5, and that cured me. Then I went to graduate school and been hanging out in academia ever since. But I went to Washington with Michael Harrington to lobby for Ted Kennedy's Medicare for All bill, which was comprehensive, what we would now call improved Medicare for all. It was a great idea that almost happened in 1972. There's a book about this. But it was Nixon was reelected, Watergate happened, and all. It didn't happen then, and it hasn't happened since. And I know, picking up on what Lloyd said, that there are people who think that no compromise. We should just push for improved Medicare for all, come what may. And yeah, I think we should have improved Medicare for all. But to keep trying the same thing and expect different consequences is supposedly a form of insanity. And I think it's great that you in New Jersey are looking to try to do something else. It has been steady work, as Irving Howe said. I'll tell you a little story, then get into the numbers. Irving Howe tells the story of a watchman employed at the edge of a Jewish village in somewhere in the Russian Pale of settlement. And his job was to announce the coming of the Messiah. Amanda asked him, you've been doing this for years and years without anything happening. Aren't you bored or something? They said, oh, well, it's steady work. For me, it's been that way. I've been writing about Medicare for all since the early 1990s. I've been doing these state estimates since 2007. I'm trying to estimate the financing, how we could actually get from here to there, tried all different permutations, done work for something like 15 states. And, it's steady work. I wish the Messiah would come, but, maybe we'll get there. And I think we'll get there by doing something like what you're talking about, which I'll get to in a second. It's a moral issue to me. I feel this passionately. I am a major user of healthcare since a cancer diagnosis a year ago. I see the bills. I am so lucky. Not only have I had wonderful doctors at Dana-Farber and locally, but I see these bills with these huge numbers and I don't pay them. I have a good insurance plan that pays it. I am privileged. I'm part of the, the top few percent. Other people I know struggle. I meet people in waiting rooms and whatever, and the financing is terrible. And for me, it's just horrific that people who are sick should have to go through this. That's a moral issue, but it's also a vital economic issue. Nearly 20% of our economy is in healthcare, and it's a growing share. It is a source of great human capital waste. I would say that to economists who don't understand morality, but they do understand that people who are trained, who have been raised at great expense, who die prematurely because of failures of the healthcare system, those people should not, it's an economic loss. And the cost of providing employer-provided healthcare, which runs to 16% of company payroll, that threatens the viability of these companies. 30 years ago, the president of Chrysler Corporation, which is now gone, said that his company was spending more for healthcare than it was for steel. Companies in other countries don't have this burden because their healthcare systems are more efficient and because they're financed separately. And if you look at it, our healthcare policy has been an abject failure. Since 1970, back down here at the bottom left, we were spending a little bit more than most other countries, and our life expectancy was comparable with other countries. Since then, that's when Ted Kennedy was pushing for improved Medicare for all. Instead, we've moved to privatize more and more of healthcare, including Medicare Advantage. As we've done that, our healthcare costs have risen faster than other countries, so that this graph's a couple years old. So in 2018, we were spending $11,000. Now we're spending more like $13,000 per person. And our life expectancy has actually been declining for 10 years. This graph goes only to 2018, so we don't have to talk about COVID. But our life expectancy has dropped precipitously in the last few years. And that is not only because of COVID. It's also because of the failure of our healthcare system. And it's not that we don't have great doctors and great hospitals. I've benefited from those, I can tell you, but it's because people don't have access. Okay, so why haven't we fixed it? We have an expensive system, but there are problems with it being expensive. Because it's expensive and because there's so much waste in it, there are vested interests in protecting that waste. I, as an economist, I can look at it and say, oh my God, we should be able to save close to, well, certainly 40% of what we're spending. If we fixed the administrative system, if we fixed billing and insurance related processes within provider offices, Massachusetts General Hospital has more people working on billing than they have beds, more than one person per bed. If we fixed that, if we fixed the waste in the health insurance companies, if we did that, we would save maybe $1 billion. But that would be $1 billion coming out of people's income. And that's a huge problem. The more waste there is, the more the vested interests there are to protect that waste. Also, the more waste there is, the more expensive it seems to be to do a global fix. Any estimates of improved Medicare for all, like mine, start with, well, how much are we spending now? And then you figure, how much could we save? How much extra would we have to spend to cover the uninsured, to deal with the underinsured, which is an even bigger expense, people who don't get health care because they don't fill prescriptions because they can't afford it, they don't go to doctors because they can't afford it. Fixing all that becomes more and more expensive the worse our system goes. The more people who are uninsured or underinsured, the more expensive it will be to enroll them in comprehensive, decent health care. These are problems. So maybe we should start small. Maybe we should build, and this is a political issue as well as an economic issue, maybe we should think about building on what works and what is popular. And there is one aspect of American healthcare that is very popular and that works, and that is traditional Medicare. It's enormously popular among the public, and also, I didn't include this graph, but if you look at life expectancy at different ages, Americans' life expectancy drops and drops and drops compared to, say, Canada or the European countries until age 65. And then all of a sudden, we start to narrow the gap. We start to do better once people get onto Medicare. Traditional Medicare has lots of problems, but it works pretty well. I wouldn't give it an A+ because it doesn't cover dental, it doesn't cover vision, it doesn't cover long-term care. I mean, there are obviously big problems that all the people like myself who want improved Medicare for all, we recognize these problems. But for hospital coverage, physician access through Part B, and the not very efficient drug program, it works pretty well. And it saves lives. So maybe we should just start there. And that's what I call the New Jersey idea. Bring everyone into existing Medicare. It's familiar. It's less expensive than doing a comprehensive program because you're not covering everything. In the numbers that I'm going to give you in a minute, I'm just talking about hospital, physician practices, and drug pharmaceuticals. We're not covering dental, we're not covering vision. I wish we would, of course, but for right now, leaving them out limits the cost. Also, I might add that, and this is where we have to allow people to supplement, Medicare, as you know, especially if you've been involved with it, it's a very limited program, limited hospital stays, limited access. Because it's limited, traditional Medicare covers only about 2/3 of the healthcare expenses within hospitalization and physician and drugs. Covers only about 2/3 of the expense for the seniors. It's a limited program. Because it's limited, we have to allow people to supplement it if we're going to put people into traditional Medicare, which is what people do. That allows space for what I call the evil private health insurance companies. Don't get me started about the health insurance companies. I'm sorry. Between them and the hospitals, I've got big issues. But although I love Mass General, I love Dana-Farber, so I do have to put that in. But the health insurance companies, they're evil. But, if we let them stay around, maybe they won't fight us so much. I mean, they're going to, and they've got tons of money to do it. But, we'll buy them off. It's a little bit like the Nye Bevan, the socialist minister of health in the Attlee government after World War II that brought in the National Health Service. His solution to opposition was to stuff their mouths with gold. It's expensive to buy out these people. In another place, I've recommended, I think I do this in my book, I recommended, let's just buy all the health insurance companies. We could bond that and pay it off with all the money we would save by just doing away with them. But okay, we're letting them stay a little bit. Also, traditional Medicare limits the financial burden of bringing everyone into the system, but it allows a basis for further progress, which was one of the ideas for Robert Bell at the Social Security Administration, who was the architect of Medicare, not the political architect, but the the one who worked out the concept. And he moved in the 1950s, he moved the Medicare for all people from Medicare for all to just Medicare for the elderly. And his idea was we start there, proof of concept. We show that we can have a working system, and then we expand it. And I would hope that that is something that would be happening here. You start with bringing everybody into Medicare, and then bring young people into a more comprehensive plan. We start giving them dental and vision, move up in age and move out in increase coverage, chipping away at private health insurance. Of course, private health insurance is going to keep on fighting. So, okay. What are you going to do? You're going to reimburse the Fed's Center for Medicare and Medicaid Services for the cost of additional coverage. Okay. My basic estimate, and this is not on the test, you don't have to know the formula, whatever, is I multiply per capita spending for each of 3 age groups for each of 3 activities. So we've got 9 cells here by the size of the population that I estimate for 2025. And I estimate per capita spending in 2025. And then I multiply that by the Medicare share of spending. I'm leaving out the Medicaid population because presumably they are already being covered, so you're already paying for that. So this is just the non-Medicare population. What we need is per capita spending by activity, which those data are not easily available. They're not available at all to me. You may be able to get them from a survey, but that would be a lot more than I can do right now. But this is a pretty good guesstimate. As you can see, the older you get, the more you spend on hospitals and physicians and on drugs, assuming growth in per capita spending at historic rates. So the older you get, the more you spend. And a lot of our spending, the largest single category of spending is hospitals, but physicians are pretty close, and then drugs are the least. That doesn't mean that drugs can't be reduced a lot if we would negotiate more, and I'm calculating some savings on drug purchasing by moving everybody into Medicare. Okay, Medicare, as I said, covers only about 2/3 of hospitals and physicians, less than that of drug spending. That's because of the limits in the Medicare system. You're going to be moving people into these things, into these programs. They're going to have some wraparound coverage. Okay, so this is what it'll cost. I get these numbers for each age group by multiplying these per capita numbers by the population in the age group by the Medicare share. So this is what it will cost to cover each individual 0 to 18, $2,000 for hospitalization, $1,700 for physicians, $400 for drugs. I mean, you can have this PowerPoint, obviously. And I also wrote a memo about it to Lloyd. Do what you will. As you can see, again, the older you get, the more you spend. $19,000 for people 45 to 64. I'm older than that, but notice the $33,000 on average. That tells you how much more seniors spend. There's a 5% of the population counts for about half of all spending. 1% accounts for, oh God, I believe it's 20% of spending. Don't quote me on that. I have to check again. I have a spreadsheet for that. You get sick, you spend a lot more. And seniors are much more likely to be sick. Plus, there's chronic conditions. So drug spending increases even faster than other forms of spending. My wife and I kind of live at CVS. Okay. How much is this total cost? If we're going to have $33 billion, if we need $33 billion to cover everybody under age 65, then how much is that going to be in terms of New Jersey? It's a lot. You're going to have to come up with something on the order of 3% of GDP, 6% of compensation, wage and salary compensation. That's a lot. 6% of wage and salary compensation is less than half what companies are now paying to cover their workers. Of course, those are companies, that includes companies that aren't covering anybody, who are paying zero. And 6% is not the end of it. Presumably, companies that now have health insurance for their employees, virtually all large companies and most middle-sized companies and some small companies, these companies are still going to be paying for some sort of wraparound coverage. The advantage of doing compensation, by the way, is it's tax deductible. Companies that pay this to the state, it's a tax. They can write it off on their federal corporate taxes. Or you could have an income tax. You could tax GDP is a proxy for income. You could have an income tax. I know that's controversial everywhere, including Jersey. You could have an income tax that would cover it. I mean, it's definitely affordable. It's a lot of money, but it's affordable. You know, and $33 billion is, to be sure, a lot less than people are spending now. Of course, it doesn't cover everything, so you have to sort that out. People are still going to have some sort of wraparound coverage, and there's still the Medicaid and the VA that I'm not including here. But it's a savings. And you get that savings, going back here to again, you get that savings mostly from the hospitals. You get some savings on drug purchasing because the Inflation Reduction Act has federal negotiation of drug prices that I got some numbers from the White House on how much they expect people in New Jersey to be saving. Yeah, they expect $100 per capita. It's not huge, but it's something. And it's only on a few drugs. Hospitals, Rand estimates that private health insurance pays 2.2 times as much for hospitals for the same activities as Medicare. I'm not assuming that you're going to be cutting the hospitals by that much, because that would be an awful lot. I don't know how well the hospitals can handle. I just threw in a number of 20%. That moving everybody into traditional Medicare, you'd have Medicare rates, and the hospitals would be worked out that the state would compensate the hospitals for some of the lower rates that they're getting from Medicare. And physician practices, I'm figuring a very small reduction in rates. Medicare rates are a bit lower than private health insurance rates, 10, 15% lower. They're different estimates. I think a lot of that is because Medicare billing is easier for physicians. Physicians tell me, and some of you know better than me on this, that you send the bill to Medicare. They may not pay you as much as you want, but they just pay. They don't argue with you. So altogether, you'll have some savings built into this. Balanced against the savings, of course, you're covering everybody. You're covering the uninsured. Right now, the uninsured don't get covered, so they, whatever. Okay, so that's my estimates. They can be refined, of course, and I always appreciate thoughts and comments and help. So thank you very much.
Thank you, Jerry. Before I ask a couple of questions, does anyone else have any question or comment about what I thought was a a very inspiring talk personally. But I'd like to just get a sense of how the room feels about this. Yes, Tom K.
Yeah, Jerry, I just wanted to bring up the point I brought up in the email, which is that, from my looking at these numbers, it's clear to me that if you go through the numbers of how much employers and individuals and unions are spending on private health insurance now, and some of that obviously to pay for Medicare would be diverted rather than those entities paying it to some private insurance company. They would pay that money instead to the state of New Jersey to reimburse the federal government for the Medicare for everybody. That there's more than enough money that is moving in that direction to pay private insurance, so that doing that shift doesn't mean that taxes are going to take any new money out of somebody's pocket. It's going to be money that's already out there allocated for healthcare. It's just going to shift from being paid to private entities to being paid for Medicare. Do you see it that way, or?
Absolutely right in the aggregate. If you take the total amount that employers are now paying for health insurance, this is a lot less. But there are caveats. There are always caveats. I think President Truman, who supported National Medicare for All, complained that economists are saying on one hand and then the other. And he said, "Can't you find me a one-handed economist?" The caveats include that some employers currently aren't paying anything. Their workers are not being covered by their own insurance plans. They may be covered by a spouse's plan. They may be uninsured completely. They may be buying their own plan. But those employers are going to experience an increase. And while employers will be paying less into this than they are for private insurance now, they're still going to have some sort of wraparound coverage for their workers. So the savings for them are not as great as they may appear. 6% of payroll is a lot less than anybody's paying for private health, employer-provided health insurance. But it's not as comprehensive as most private health insurance plans are. One thing that I didn't bring up here, following up on Tom's point, is that public employers pay a lot more for health insurance than do private employers. I haven't looked at this in particular in New Jersey, but I know every place else that I've looked, it's over 20% of payroll, because public employers' plans are more generous generally, but mostly it's because public employers cover families. So what happens is you have somebody working a small construction company, whatever. He doesn't have health insurance through his employer. His employer is paying nothing now. But his spouse works for Rutgers or some other public entity, and they cover the whole family. So that, what we're talking about here is actually would be a huge boon to the state budget in that area. So overall, Tom's absolutely right. Aggregate, if we're spending less on health insurance, if we're more efficient, then we're going to be spending less. But they're going to be winners and losers along the way. If you do it by an income tax, then there'll be another whole set of distributional issues.
One question I have for you, Jerry, and if you could care to speculate on this. I mean, New Jersey doesn't have a patent on this idea. I mean, it's open to any state that would care to do it. No state has indicated any such interest in this. Do you want to speculate on why that might be, or why what we're doing might be outside the box? Do you think it's a good outside the box, or do you think we're going in the wrong direction?
No, I absolutely think you're going in the right direction. I think a lot of people involved in the Medicare for All community Max Weber distinguishes between people who live for politics and people who live off politics. People who live for politics are devoted to the issue. They care a lot, and it becomes performative for them. Don't quote me on that word, because these are really well-meaning people. Someone just wrote the other day in Common Dreams, a very nice person I know, very caring. She's been devoted to this for decades, attacking the idea of doing a state plan at all. We should only go for a national improved Medicare for all, no compromise. Well, that feels great for some people. They feel like they're pushing for the right thing, and they are pushing for the right thing. But pushing for the right thing doesn't have to mean you don't make any compromises along the way. And that's where we need people who are living off politics. We need people who are ready to make compromises as long as we're moving in the right direction. Now, I think when I've talked to people about, well, you could save money on a state plan or a national plan by dropping some coverage, people often get very agitated around the issue because they want the right thing, and they are absolutely right. We should have the right thing. But look at Bernie Sanders. He's been in there, okay, we're not going to get Medicare for all, so let's try to get drug coverage, dental coverage, vision coverage, and a cap on out-of-pocket spending. Couldn't get that through, so let's get drug coverage, negotiated drug prices. We got that through, and now he's going to be pushing for the next things. Robert Ball, the same. We can't get the whole thing, so let's get a piece and use that as the basis for moving forward. So I think you're absolutely in the right path, and you're going to get some criticisms from people who aren't willing to make any sort of compromise because it feels good that way. The fact that people aren't getting better health care, somehow gets lost in the shuffle of people's focus on doing what they see as the right thing. I really don't mean to criticize anybody here.
No, I understand where you're coming from.
Yeah.
And anyone else? Any thoughts, questions? Josh, you had a question or a comment?
Yeah, a few questions, if you don't mind. Number one, what I think you're proposing, and I just want to clarify it, is you've estimated how much it would cost to cover everybody in New Jersey on Medicare, and the preferred way of financing this is through an employer tax, which would be less than they're paying for their current coverage of employees. That's the first question. I think that's what you're proposing, but I just want to make sure that's correct. Secondly,
before you go any further, we really haven't specifically proposed any way to finance this, and that's nowhere in our bill. And that was the reason we asked Jerry to speak today. There are many ways we could try to finance this. I mean, I could get creative here and talk about taxing gambling winnings or sports betting or lottery winnings. There are many ways to get increased revenue streams. That's really that wasn't the purpose of the bill when it was first introduced. The financing would come later, we said. But anyway, go ahead. I don't want to interrupt your train of thought.
Okay. So, and the second question is, obviously there's money in the system right now through what both the state and federal government pay on Medicaid, which I assume would go into this pot to cover everybody, hopefully the Medicaid population, and also for the ACA subsidies would go into a pot. I'm thinking financing, Lloyd, because the objections to the bill will be, how do you pay for it? So I think talking about financing is helpful. The third question is, you talk about rates going down for hospitals. What they will be reimbursed from Medicare will be going down for both hospital and doctors. But do you factor in also the savings that the doctors and hospitals will experience because they will have to hire less personnel for billing and administration. And the last question is having to do with supplementing coverage through Medicare supplemental policies, which those of us on Medicare now pay for, but will be hard to afford for lower income persons. So what do you think of including subsidies for people to buy or Medicare supplement policies, let's say for people below 200% of the federal poverty level?
These are all really good points. And mostly I haven't gone into them. I was just looking here at the global picture. As far as Medicaid goes, I've left that out. Medicaid won't be changed. It's a comprehensive plan. These people are already being covered. We're not touching them. They're not going to be moving into the Medicare system. Medicaid is also a very cheap plan because they pay such low rates. You're absolutely right that doctors and hospitals will be saving money. I think the savings won't be as great as they would get with a improved Medicare for All plan, because they're still going to have multiple payers with the supplemental plans, but there definitely should be savings. ACA subsidy should definitely be part of the picture. I didn't look at them here. There are other public health spendings that would be able to, the state would be able to cut back on, that, the state would be saving a lot of money on employer health insurance itself, and local governments will be saving those funds that may be able to be redirected into here. The total picture, I brought up the payroll because that's kind of the natural way to cover everyone, since Medicare is currently financed with a payroll tax and employers are currently providing health insurance at some expense. But absolutely, as Lloyd says, doesn't have to be. It doesn't have to be that way. You could do it with an income tax. You could do it in lots of different ways. You could do it as a property tax. I haven't gone into that issue, but these are good suggestions. Thank you.
One of the concerns as far as doctors are concerned, which I could certainly speak to, is that it's going to be hard to get them on board if they are told they would have to accept Medicare rates, period. And Medicaid pays so poorly in New Jersey that there are doctors who don't accept Medicaid.
Yeah.
So that is going to be a problem. We would have to somehow build into this financing a way to bring the doctors up to what at least they would consider a fair living wage. And how that's done, I really don't know at this point. Maybe we could have Medicare plus a bonus or something to that effect. That's to be determined. But unless we get doctors on board, this is not going to work. And we have to find a way to do that.
Absolutely, and I don't think that should be that hard. I factored in a very small reduction in physician reimbursement rates. Doctors will, as Josh pointed out, doctors will be saving on billing and insurance. They won't be capturing all the savings that they get with a single payer, but they'll be able to cut back. Whenever I go into a doctor's office, I always stick my neck around the corner and look at all the people sitting there at computer screens filling out forms. And I have several neighbors and friends who are doctors. They talk about the insult, the professional insult, as one of them says, of having to talk to some snot-nosed in Omaha who knows absolutely nothing about medicine and nothing about my patient, and plead with them to be able to treat my patients the way they need to be treated. So I think, these are absolutely, getting the doctors on board, I think, is absolutely essential. They're a group that has real clout in society. The uninsured and the homeless have no leverage, which is terrible. They should. They're important, but whatever. But doctors do, and we need to get more of them involved. Something like what, 6% belong to Physicians National Health Plan. And I think part of it is they feel like, a lot of people feel like this is a hopeless cause. You
Yeah.
know,
Anyone else have any thoughts? I just have one. Yes, Michelle.
I wonder, how is this different than Medicare for All? I mean, sorry, how is this different from Medicare Advantage?
Well,
well,
go ahead.
okay, it's not a private plan, for starters. I'm talking about moving everybody into traditional Medicare, not Medicare Advantage type plans. This would be, I'm assuming this would continue to be administered by CMS. It's different from what people talk about as Medicare for All. When people talk about Medicare for All, as in Bernie in 2016, the plan I did for him was comprehensive. We were going to cover everything. This is not covering everything. This is only covering what traditional Medicare now covers, which is why people will still have to get supplemental plans.
So you'll still need insurance companies.
Which
Yeah.
is a plus and a minus. It's a plus because it means the insurance companies may not fight us as much, but it's a minus because we'll continue to have a certain amount of waste in the system. Insurance administration and the billing and insurance related expenses in the provider practices.
Thank you.
Well, if no one else has any
Lloyd, Bill has a question, I think.
Oh, I'm sorry, Bill, did you want to comment, please?
Well, yeah, just a quick comment about strategy. And Dr. Friedman mentioned, Bernie Sanders' efforts in the last year to really try to expand Medicare benefits. I'd like to try to reiterate that even though most of those things didn't go through, we did get the partial drug negotiation piece through. But in my years of speaking about Medicare for All, the biggest block for seniors moving from traditional Medicare to the Part C Advantage programs was the fact that they didn't have to buy supplemental insurance anymore. And they had out-of-pocket maximums in those things, although those have gone up over the years. So expanding traditional Medicare benefits as a strategy right now really has a major advantage. It's a positive approach to expanding coverage, which will at the same time sort of let supplement policies and Medicare Part C kind of die on the vine, just like they did back in '95. When they all folded and the Republicans came in to save them with higher payments. So I think, we really need to focus on expanding the current benefit structure of Medicare. And especially this piece about an out-of-pocket max is really important to most beneficiaries. It's a very kind of quiet thing, but it could change the industry entirely. It would give people confidence to stay in regular Medicare and not go into the Advantage programs. And it would also kill off the supplement programs, which are essentially a siphon on the Medicare system. They have a medical care loss ratio of about 85%. So it means 15% of the money is just being ripped off by these companies who do nothing other than take your money and pay the bills that ought to be paid by Medicare. So that's my comment.
Absolutely right. I totally agree. Yeah, I was very involved for a few years in efforts to get an out-of-pocket cap on Medicare, traditional Medicare. It's the only insurance in the country that doesn't have an out-of-pocket cap, and it's terribly destructive. It means, for whom does it matter? It matters for people who are really, really sick. And those are the people we're screwing completely backwards.
Yeah, that's going to cost money, and that's the problem because, there are people in our government that just don't want to spend.
Yeah, well, it's gonna cost money, but as Tom would say, it's money that's already being spent. It's
Right.
just shifting the money around, and so much of the economics around here, around healthcare, has to do with shifting money from sick people to the total population, or or back the other direction.
Yeah, compare 2% for overhead for Medicare and 15% overhead for supplement programs and advantage programs.
Yeah, there's your profit. And it's money that's also going to media companies, in advertising buys, and banks in processing fees. There are people who are making a lot of money off of our healthcare.
And, the population right now, for those people who are actually using advantage programs, this campaign against advantage programs looks like you're trying to take away a program from that part of the population.
Now, it's much better to focus on improving traditional Medicare, as you say, than attacking advantage plans that are used by half of Medicare recipients and defended by all sorts of Democratic and as well as, of course, Republican politicians. Get an out-of-pocket cap, expand traditional Medicare, and the flow of people will go back towards traditional Medicare with all the savings that come from that.
Great. Tom K., did you have another comment?
Yeah, I just wanted to comment on a couple of things. One is not to forget that, Jerry, you alluded to Kay Tillow's article, I think, about
Yes.
the state single payer plans, and we avoid the pitfalls because her main argument is that you're giving states control over healthcare and you're actually dismantling Medicare, but we're not. We're going to add 7 million people to the rolls of Medicare. That's going to expand the risk pool for everybody in New Jersey as well as nationally, and so that there's benefits from that. And we're trying, and at the same time, our legislation is kind of an advocacy for Medicare for all, because we're saying if our state and some others had the same bill, we'd all be saying, put everybody in Medicare. That's so we're trying to do the expansion of Medicare. The improvement, of course, is another matter. The other point I wanted to make is you talked about leaving Medicaid out of it. Our bill actually says that everybody's in Medicare. So that includes people on Medicaid. But of course, the federal government would require that we ensure that all of the Medicaid benefits are available to the low-income folks who are now getting Medicare. But it's important to put everybody in Medicare because it eliminates this distinction, this stigma that goes with the differences between whether you're covered by New Jersey Family Care or whether you're covered by Medicare or private insurance. And so, and then the question of a Medigap, one thing the state could do is it could take some of the money that it's putting into the system. And you talked about the state and local government savings. One of the things that the state could do is provide a Medigap program for low-income people that would make it more affordable, and so that it would be kind of a state Medigap plan that New Jersey could put in place that would meet that need. So a few things I want to pick up on.
They're very good. Thank you. Thank you. I didn't realize that about the Medicaid. It's very helpful. And you're absolutely right. The state, well, certainly people below New Jersey is at 133% of poverty line for Medicaid. Those people, the Medigap would automatically be paid out of what's currently going into Medicaid. And those between 133 and 200%, which you mentioned earlier, those people are largely getting subsidized insurance through the ACA subsidies. So the money's there, mostly there. I haven't worked this out, but the money is mostly there already.
Just one last question for you
Yeah.
before you run. Do you have any thoughts about why, for example, more people aren't paying attention to this problem? Why isn't healthcare more of a kitchen table issue than it is? While it's under the radar screen, we have rural hospitals and safety net hospitals closing. We have private equity taking over nursing homes and hospital practices and doctors' practices, and yet nobody seems to care. And for the life of me, I just don't get that. And I don't know why this is not more of a kitchen table issue that everybody's talking about. What are we doing wrong?
I don't think, well, I so totally agree with you. And, we have a lot of activity around other issues, and I won't name them, but my wife will go on to me about how come people aren't paying attention to the most important issues around climate catastrophe and healthcare. Trump drives out all other concerns, the fight for democracy in America, which is, and the rule of law, fundamental. Wars, it's really hard to break through, but I think that we just got to keep on pushing, steady work.
Yeah, got it. Well, thank you very much.
Okay, I gotta
won't
go.
keep you any
but
longer.
Thank
Okay.
you so much.
All right.
This has been a lot of fun.
Thank you.
Okay. You'll hear from me later today.
Sure. Take care.
right.
Bye-bye.
Okay. Before we wrap things up, does Linda, you want to say something?
I wanted to know more, the book. I didn't catch what it is and where to.
It's called The Case for Medicare for All. It's written by Dr. Friedman. It's available, as he said, it's available on Amazon, or he said go to your local bookseller to buy it because he wants to support the local bookseller.
Is
I
it
can understand
recent?
that. But it's not expensive. It's probably available at a few libraries, I would imagine. It's a good read. It's simple, it's direct, it's cogent, and it's moral. It's very, very well written, and
Yeah,
I recommend it.
yeah. Good
Okay.
speaker. Thank you.
Anything else before we wrap up for the morning? All right, I'd like to thank all of you who are on the call. James, did you have a comment or no? Okay.
Yeah, I just wanted to ask a question. I think I've worked with Tom and a number of politicians, trying to get them more information on these plans. But I live in Gloucester County, LD3. I have two new assembly persons, Heather Simmons and Dave Bailey. I have a new senator, John Berticelli. If I can find out what committees these legislative plans are going to, maybe I can find out if I can meet with them. I have a meeting on another issue with Dave Bailey in about a week or two. So if I know that he's on the committee, I can kind of see if I can get a meeting with him.
Yeah, I don't know that we really thought that far ahead. What I would suggest is mentioning it to Assemblyman Bailey or Senator Bailey when you're there at the meeting. And
yeah, I was going to do that.
If you can, at least download the existing bill and bring it with. It's only 3 pages.
Yeah, okay.
And just leave it with him or his staff and just say, please look at this.
Yeah.
The more people we can get engaged, I think the better chance we have of getting it before a committee.
Okay. Thank you.
Paula?
Yeah, I'm going to need some help in contacting people who can help me with getting Congressman Gordon to support this because I'm ready to reach out to him. But my list has been an old list. So if anybody has anybody in Bergen County that they feel I should be contacting to work with me to get up a committee to go see Representative Gordon Johnson, I'd appreciate it.
And yeah, we'll put feelers out certainly. I do want to thank everyone who is on the call today and for their time and attention. I think it was well worth it. And with that, I will move for adjournment unless there are any last minute thoughts or questions. All right, happy weekend, everyone. Enjoy the eclipse and stay safe. And we'll see you all real soon.